Welcome to today's Explainer. Look, if you're a medico, whether you're a medical student or resident or an attending physician, you have probably heard the standard public health messaging around vitamin D 1,000 times. You know the drill. Get some sun, drink fortified milk, maybe take a supplement. But today, we're moving far beyond the basics. Our goal is to really equip you with a rigorous, high-yield clinical understanding of vitamin D deficiency. We're going to dive into the exact pathophysiology, the hidden diagnostic traps that catch out even the most experienced clinicians, and the definitive evidence-based protocol for repletion.
Okay, let's quickly run through our agenda for today. We've got 6 sections. 1, the clinical vignette hook. 2, epidemiology and synthesis barriers. 3, immunology and cellular pathology. 4, diagnostics and clinical pitfalls. 5, the repletion protocol. And finally, 6, maintenance and prevention.
Section 1, the clinical vignette hook.
Let's kick things off with a real-world case that perfectly highlights why we need to keep a high index of suspicion. Imagine a 34-year-old software engineer working from home in Bengaluru, stuck indoors for literally 14 hours a day. She presents with a 3-year history of chronic fatigue, frequent colds, we're talking like 6 a year, bone aches, and mood swings. Now, her labs unexpectedly reveal a severe 25-hydroxyvitamin D3 deficiency at just 8 nanograms per milliliter. Consequently, she's got secondary hyperparathyroidism with her PTH spiking to 82. And get this, at just 34 years old, she already has a bone density Z-score of negative 1.8. That indicates osteopenia. And guys, this brilliantly illustrates a major diagnostic pitfall. Look at how easily a patient like this slips right through the cracks. In her initial visits, her doctor notes, well, she's young and eats well. The standard CBC, thyroid function tests, and fasting blood sugars, they all come back completely normal. And this leads to what we call symptom convergence. Her fatigue, the bone aches, the mood swings, they are all erroneously bundled together under a psychotriac label. It is a massive missed opportunity simply because vitamin D was not tested. Once she finally got that test, a simple, targeted supplement resolved 3 years of debilitating symptoms in exactly 8 weeks. Just like that.
Section 2, epidemiology and synthesis barriers.
Brace yourselves for this jarring statistic. A staggering 76% of the Indian population is silently deficient in vitamin D. It is a true silent epidemic affecting over 1 billion people, and it puts the 60-plus age group at an especially severe risk. Now, what's genuinely fascinating here is the profound geographic paradox. Think about it. India receives over 300 sunny days a year. Intuitively, a population living under that much sun should have incredibly robust, optimal levels of vitamin D. And yet, we are seeing endemic deficiency across the entire subcontinent. So why the disconnect? Well, to understand why, we have to peel back what I call concentric layers of impedance. Think of these as massive systemic roadblocks to natural vitamin D synthesis. We start at the surface with SPF 30+ sunscreens, which block up to 97% of UVB rays. Then, add our modern indoor lifestyle behind UVB-blocking glass, the protective clothing we wear, and of course, severe air pollution. But on top of those environmental factors, we have profound biological barriers too. The obesity epidemic literally sequesters this fat-soluble vitamin right into adipose tissue. Aging drops our skin's synthesis efficiency by 50% by the time we hit 70. And darker skin melanin actually acts as a natural SPF 13, meaning it requires significantly more sun exposure to synthesize the exact same amount of vitamin D. And here is the kicker. Even when your patients actively try to get some sun, they usually fail. Why? Because natural synthesis demands some incredibly strict physiological rules. First, they have to hit the optimal UV zenith angle between 1:11 a.m. and 1 p.m. for at least 15 to 30 minutes, 3 times a week. Second, just exposing the face, not going to cut it. Arms and legs must be directly exposed without any glass in the way, because window glass completely blocks UVB. And crucially, they've got to wait about 30 minutes before showering to preserve the skin oils where the synthesis actually begins. Sunscreen should only ever be applied after this exposure window. Section 3, immunology and cellular pathology. All right, let's zoom in microscopically. Biochemically speaking, the absolute crucial point is calcitriol's interaction with the vitamin D receptor, or VDR, inside our immune cells. This stuff is fascinating. In macrophages, calcitriol upregulates peptides like catheliticin and defensin. These are essentially responsible for the direct intracellular killing of nasty pathogens like Mycobacterium tuberculosis. But simultaneously, it's modulating our adaptive immunity too.
It tones down the Th17 inflammatory cytokine storm while actually increasing regulatory T cells to prevent autoimmunity. It even optimizes B-cell antibody production and strengthens the tight junction proteins of our innate immune system, actively lowering inflammatory markers like CRP and IL-6. So, make no mistake, this is a master regulator of immunity, not just some standard bone vitamin.
Section 4. Diagnostics and clinical pitfalls. As a clinician, you absolutely must commit these precise diagnostic ranges to memory. Remember, the active form, calcitriol, is activated in the kidney, but we are testing for the precursor. Severe deficiency is anything below 10 nanograms per milliliter. Deficient is under 20. But please note, our optimal target for patients is strictly 40 to 60 nanograms per milliliter. Letting those levels slip leads to the classic signs we all learned about: rickets in children, presenting as craniotabes or a rachitic rosary, and osteomalacia, marked by looser zones in adults. And hey, be acutely aware of the toxicity threshold as well, which sits up above 150 nanograms per milliliter. Okay, I want to test your clinical acumen for a second with a major red flag scenario. Imagine a 45-year-old woman presenting to your clinic with bone pain. What is the hidden danger if you notice in her chart that she is on long-term anticonvulsant therapy? Got it? The answer is a massive diagnostic trap that catches so many doctors off guard. Anticonvulsant therapy triggers the induction of cytochrome P450, specifically the CYP3A4 enzyme. This enzyme rapidly degrades vitamin D, so the patient's 25-hydroxy levels will absolutely plummet, in this specific example all the way down to 12. This leads directly to elevated PTH to compensate, causing secondary hyperparathyroidism. If you x-ray her femur, you're gonna see looser zones. The correct diagnosis here isn't just routine deficiency, it's drug-induced osteomalacia, caused by the accelerated degradation of vitamin D. Section 5, the repletion protocol. First things first, we've got to accept that conservative, native interventions completely fail in the face of severe deficiency. A patient requires 2,000 to 4,000 IU daily just for baseline therapeutic requirements. If you tell them to just, eat better, it won't work. An egg yolk only provides about 40 IU. Even fatty fish like sardines only give you 600 to 800 IU per 100 grams. Diet alone is mathematically impossible for clinical repletion. And sunlight, it's simply too slow. It takes 3 to 6 months to natively correct severe deficiency, which leaves the patient's organ stores compromised in the meantime. So, when a patient's levels are sitting at rock bottom, we need a fast, kinetic, 3-step pharmacological pathway. Step 1 is loading. Step 2 is maintenance. And step 3 is strict monitoring. All right, here is your high-yield, definitive clinical protocol. Step 1, load them with cholecalciferol, or vitamin D3, at 60,000 IU once weekly for 8 weeks. And here is a totally vital clinical rule. Tell them to take it with a fatty meal. Because it's a fat-soluble vitamin, doing this provides a 30% absorption boost. Step 2, transition them directly to a daily maintenance dose of 1,000 to 2,000 IU to prevent recurrence. You can also consider vitamin K2 co-supplementation and definitely ensure 500 to 1,000 milligrams of calcium are included. Finally, step 3, don't guess. Recheck their blood levels 3 months post-loading to confirm you have actually hit that sweet spot, the optimal target of 40 to 60 nanograms per milliliter. Section 6, maintenance and prevention. Now, fixing the immediate problem is only half the battle, right? We also need to prevent recurrence through proactive guidelines. You must tailor your maintenance dosing to the patient demographic based on the ICMR standards. Infants need about 400 IU a day. Standard adults need 1,000 IU. But pay super close attention to your vulnerable populations. Pregnant women and the elderly require much higher daily intakes, ranging from 1,000 to 2,000 IU, or even 1,500 to 2,000 IU for seniors, just to maintain bone density and immune function. And always flag high-risk individuals like indoor IT workers or shift workers for routine monitoring. As we wrap up today's explainer, I want to leave you with a final, somewhat provocative thought. The sun is completely free, and your patient's immunity is absolutely priceless. Yet 76% of the population is walking around deficient without even knowing it. Their symptoms hiding behind vague complaints of fatigue and body aches. We have the exact, precise clinical protocols to fix this. So you have to ask yourself, in a world where systemic biological failure often masquerades as simple fatigue, are you testing aggressively enough to ensure your patients aren't part of that silent 76%? Seriously, one single blood test really can change everything. Thank you so much for joining me, and I'll see you in the next one.